I'm back, Johnna.
Antoinette, just curious what our registration number was at. How many were we expecting this evening?
Yeah, we had 70 sign up.
70, okay.
Yeah.
Ooh, we're a little ways from there.
Yeah.
And just to clarify, I won't be doing all the preamble, right? I saw the agenda. I just wasn't sure who was doing what. Pardon me.
Yeah, Crosbie, I'll get us started and introduced, and then you can kind of sit back and relax for the first few minutes and then take it away with your presentation.
Okay, thanks. And about half hour, right?
About, yeah. If it's a bit longer, that's okay. Shorter, that's okay too, because we'll do breakout rooms and then Q&A to finish up. So there's always, yeah, lots of other things we can do. We just adjust those times sort of based on your presentation. Yeah, thank you for being here. Thank you for presenting for us.
Oh, you're welcome. Yeah. You're seeing me okay?
Yeah.
Okay,
Yeah.
because
The view is
yeah, the view, that's fine.
it's a bit funny when it's showing you're seeing the intro screen with the physician learning project.
Speaker. Oh yeah, there's everyone. Yeah. I just
Yeah.
had yeah. Good.
It's nice to at least see some faces and not just a slide, hey?
Yeah.
Yeah, and for anyone else who might be on and wondering, you can hover up in the top right corner on view, and that will change so you can at least see a panel of faces, or set it up to just see the speaker, or gallery, see more faces, or full screen will show the slide. Great, okay, well, we're a few minutes after the hour here, and I know people are still logging on, but our presentation is being recorded, and I think in the interest of time, we'll get started and start, getting things underway here. So welcome everyone, and thank you so much for logging in and joining us tonight for another one of our physician learning projects with session 6 this evening, and this is the failed promise of modern psychiatry, and we have the fantastic Dr. Crosbie Watler here with us tonight. And I'm Dr. Johnna. I'm the GP family physician lead of this project, and I'm working alongside with Dr. Rob Comey, who's our psychiatry lead, as well as Ellie Molnar, our project manager, and basically the brains and brawn behind this operation. So yeah, just really acknowledging them and appreciating all the work that they've put into this, as well as our scientific planning committee and other members, including Dr. Pam Crisco, who is here as well, I believe. So before we get started, I'd like to just do a land acknowledgement, recognizing I live, work, and play between both Cortes Island and Cumberland, and Cortes being the home of the Klahoose First Nations, Cumberland, the Comox. However, this evening I'm actually tuning in from Toronto, and there's many First Nations here who traditionally were living on the lands before us, the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Wendat peoples. And so taking a moment to just acknowledge your own local First Nations. And so this project, it's a series of 7 monthly presentations. Here we are already on our 6th session. We'll have one more in December, and then we're hoping to actually proceed forward with some more in the new year. So do please let us know if there's any topics or speakers you'd like to see. You can Either email us through Antoinette, or you can include this in your evaluation. And our goal is to help increase awareness and knowledge of the utility of psychedelics in the mental health and wellness realm, specifically as healthcare providers, physicians, and nurses, as well as give an opportunity for network amongst those of us who are interested and gain some CME credits in the process. So yes, your attendance is recorded for CME credits. So just a friendly reminder that in order to receive a CMA certificate, we need to be able to identify you. So including your first name and last name in your Zoom identification there, or making sure that you complete the attendance survey and identifying who you are. And Antoinette will provide a link for this in the chat box. We also really appreciate getting feedback and having our evaluations done. So I do ask you that you kindly consider doing this at the end of our presentation this evening. And of course, sending along any feedback that you do have for us to help make this series better and proceed forward. The session will be recorded except for the breakout room sessions, so you can come back and re-review and share it with those who may have missed. And for our Q&A portion at the end, we found it works best if you enter your question in the chat. So please write down any questions that may come to mind and then prepare them and type them, enter them in the chat box following the presentation, so we can try to cover as many questions as possible. And so tonight we have Dr. Crosbie Watler here with us. And Dr. Watler received his Master of Arts in Psychology before then going on to do medical school, getting his MD at McMaster and completing a psychiatry residency at Dalhousie University. Woohoo! That's where I went for residency as well, and I know a few other people here this evening. He worked for 5 years as the chief of psychiatry at the Lake of the Woods Hospital in Kenora, and there he served for a year as the chief of medical staff. He then moved with his wife and 3 children out to Duncan in 2001 and presently resides in beautiful Maple Bay. He had a busy practice with Island Health for 19 years doing inpatient, outpatient, tertiary care, and assertive community treatment. And he also served as the department head of psychiatry and the medical director for Island Health's mental health and substance use program between 2015 and 2019. So very busy career there. And his current focus is holistic health and getting to the upstream mediators of our current mental health and substance use crisis. He had a past affiliation with Therasil, which works with compassionate access to end-of-life psilocybin. And he's currently affiliated with the Roots to Thrive ketamine-assisted psychotherapy project, as well as the My Community Thrives nonprofit, who very excitingly last week hosted the first legal group of psilocybin in North America. And currently he also works part-time at Cedars Cobble Hill, doing residential substance use treatment center work. So without further ado, I will pass it over to Crosbie, and you, I can see already, have a wealth of experience and knowledge to share with us. Thank you so much for being with us this evening.
Thanks, Johnna. So if you'll set it up so I can screen share.
Yes.
You need to make me host. Or...
Antoinette or Kristen, if you could make him co-host.
I think Kirsten, I think you can.
Yeah, he doesn't, you don't need anything. You can just screen share. You don't have to do anything. I don't have to.
Yep. Just one moment here.
Is it giving you the option there, Crosbie?
Yeah, it's just, let me try again.
And Antoinette, I'll ask you as well while we have a moment here, if you could pop the evaluation link in for people as well there in the
Do you
chat.
want the mid-series or
Yeah.
both the mid-series? Okay,
The mid-series, and then at the end, we can do our end
sure.
one here. Yeah, thank you. There it is, we can see it.
Finally, sorry about that.
No worries. This is how Zoom is.
Oh, yeah.
Feel free to take it away. Thank you.
Okay, thanks. So I just need to get to the start. And I'll just change the view here. Yeah, so thank you for inviting me. My topic is a little provocative, the failed promise of modern psychiatry, but at this stage, I'm not too shy about calling it as I see it, then presenting the data to support it. So here we are in 2021, and we have 11% of the population on antidepressants. We have a rampant increase, exponential increase in prescribing medications over the past 20, 30 years. And we're having increasing awareness of the poor efficacy and tolerability of medications. And the lifetime prevalence of any mental disorder is almost approaching certainty, right? 65 to 85% of persons will be diagnosed in their lifetime with some form of mental disorder. And despite all of this, we have an exponentially higher number of people on a per capita basis off on disability for mental health and substance use challenges than ever before. So clearly something is missing. And we are aware of this other not so silent pandemic of new record opioid deaths, record disability rates for anxiety, depression, record prescribing rates for antidepressants, and a lot of healthcare provider burnout and therapeutic despair, not having the best outcomes for patients. And I guess we need to learn, as more and more funding is being allocated to mental health and substance use, we need to learn from the past and make sure that with our new tools that they're incorporated as quickly as possible, and we're not using more and more of the strategies that haven't worked so well for us based on the data to date. How we got here, I reflect on my journey in psychiatry. I entered psychiatry training in the early 1990s, the decade of the brain. And that was a very exciting time. We genuinely believed this was a new frontier with the rollout of novel antidepressants and antipsychotics. And we believed we were right on the cusp of figuring everything out above the neck in the brain and finding the markers for mental disorders and finding definitive treatments, much as the rest of our peers in medicine have had for decades. And the psychiatry curriculum was heavily biased towards the diagnostic interview and prescribing. And the ones that had the prestige were the biological psychiatrists, and the psychiatrists who were more of a psychotherapy band were not getting very much recognition. So how are we doing? Some 4 decades later, the origins of mental illness still remain a mystery. And DSM-5 lacks the data to define mental disorders in the way that physicians conceptualize medical illness. In other areas of medicine, medical illness, there are specific biological markers, and these lead us to definitive treatments with pathophysiology that is known. But that has not stopped the mission creep of psychiatry, because with every edition of DSM, we see more and more diagnostic categories and the medicalizing of the problems of living as mental disorders. And psychiatric classification has become seriously over-inclusive. And Joel Paris is a very senior Canadian psychiatrist, and he has a couple of little books that are page turners. And I can send the info to you by email if you like, but Intelligent Clinician's Guide to DSM-5 and Overdiagnosis in Psychiatry. And this is a somewhat indicting statement by Joel Paris. Just because we list something in DSM-5 does not make them real. And this is a great challenge, because when patients hear that they have a disease or a disorder, they look at that as equivalent to any other medical doctor saying you have hypothyroidism or you have diabetes. And it is very challenging for me to retell the story sometimes. So there is harm being done, because the patient has the impression that there is something wrong with them medically. And of course, they are looking for the pill for every ill, and that is not working so well. So in the rest of medicine, we understand that a diagnosis is a specific condition where the nature and the cause is defined. And it also directs our medical decision-making and also speaks to prognosis. A syndrome, on the other hand, is a collection of symptoms and findings without necessarily trying to identify a single identifiable pathogenesis, even if that were possible. And in medicine, chronic fatigue syndrome, irritable bowel syndrome, and unfortunately, depression, well, it is what it is. Depression is a syndrome. Anxiety is a syndrome. And until about 1980, there was some recognition that depression was not a discrete disorder. Those of you who may be a little older might remember through DSM-3 up until 1987, there was endogenous and reactive depression. Well, that was very significant. Reactive depression was construed to be distress in response, in reaction to something going on in one's life, whereas endogenous depression came de novo without any clear trigger. And the common culture at the time was, you don't treat reactive depression with medication, right? You look at the source, you look upstream. But with DSM-3R, if one is sad, they have major depressive disorder. And hence, we're catching more and more people in this net, if you will. And as I've said earlier, our patients are not faring so well. And we need to distinguish the difference between distress and disease. Distress versus disease. So is the patient truly at the center of care? When we are in a culture where just about everyone is a psych patient. Everyone who is distressed or struggling is a psych patient with a diagnosis and a medicalizing of the human experience. And the challenge is to discern, deconstruct these syndromes so we can make sense of the individual human being that is sitting with us and looking at them through a more holistic lens, as opposed to neuroreceptors that are the source of their suffering. So unfortunately, the industry of care is doing way better than are the outcomes from care. And unfortunately, busy practitioners are being reimbursed for face time, not for outcomes. So it's very challenging with very busy professionals who are making a good living and I believe, working from the heart, it's very challenging to engage them about different ways of working and more about accountability around outcomes. So this is a real challenge in psychiatry, the rising treatment resistance. So the therapeutic benefit from antidepressants, this is a well-known fact, barely separates from placebo. And of those that respond, only a minority will realize full remission. So there is a striking credibility gap here in continuing to call these medications anti-anything in comparison to other areas of medicine. If I had a colleague who was an infectious disease doctor, and I said, look, we have this anti-medication that, separates barely from placebo. How's that compared to your antibiotics? And yeah, so there is a huge credibility gap. I often say, if antidepressants truly were antidepressant, I would be out of work. And this also creates unrealistic expectations for patients and an increasing sense of helplessness and hopelessness when we have trial after trial after trial with poor outcomes. Now, this is not to throw the baby out with the bathwater. The challenge here is to deconstruct the syndrome of depression for the individual person that you're treating, and to understand whether one can make sense of the depression. Is the depression more an adaptation to some other upstream mediator, like fever, perhaps? I use fever as an analogy. If someone comes into your office and they have fever, we don't say, oh, your diagnosis is fever. We know that that is a call to action to look upstream. And similarly, when someone comes in and says, I'm sad, again, that's like fever. What's the source? What is the source? And to lump everyone in as DSM-5 has, to say everyone who has this checklist has the same thing is not credible. So we are really a call to action. Instead of blaming the patient for being treatment resistant, perhaps it's time to recognize that for many of our patients, we're simply using the wrong treatments. And I'll just share a little, not very common scenario. Looking at the benefit of antidepressants, barely separating from placebo, we lose a lot of data looking at that. We actually have a bimodal sort of distribution in terms of patient response. Patients who have a more melancholic or endogenous depression actually do very well with antidepressants. So I would invite you to look up in DSM, because there is a specifier under major depressive disorder called melancholic subtype. And there was a lobby in DSM-5 when they were putting it together that melancholia should have been a separate diagnosis to capture its distinct quality. But that was overturned, right? So we need to recognize that the diagnoses in DSM are not defined necessarily by science, but by people sitting around horse trading what's going to be in, what's going to be out. So making Joel Paris's point, just because we call something a diagnosis does not make it real. So it's very important as physicians, those that are prescribing physicians in the audience, to not throw the baby out with the bathwater. Every now and then I see someone with a melancholic endogenous depression and I reach for the prescription pad, in addition to supportive psychotherapy, instilling hope, all that other good stuff, and explaining what's going on. And I say, yes, here is one who actually a prescription is very likely to be of some benefit. So again, it's deconstructing the syndrome. But for the vast majority of people with anxiety and depressive symptoms, there are very predictable upstream mediators that we can identify. In functional or integrative medicine, it's about telling the story. and this is not unique to psychiatry. We look at metabolic disease, right? Instead of saying, well, you have this disease, this metabolic condition, well, perhaps it's more of an adaptation to the lifestyle mediators upstream. So I think, to be fair, I think all the medicine needs to look more and more upstream. But I think psychiatry is perhaps a special case, because the burden of suffering presently from mental health and substance use has become intolerable, frankly. So with these folks that are struggling with upstream mediators that we cannot help with our current tools, we've labeled distress as disease. And a very indicting statement by Darian Thera: psychiatric diagnosis is the naming ceremony of colonization. So the pre-disease model. So through the 70s, into the rise of CBT and Aaron Beck, the cognitive triad, depression often occurs in the context of a negative view of self, world, and future, the so-called cognitive triad. And before Aaron Beck, psychoanalysis, recognizing that there is things that we suppress, increasingly so in our frenetic 21st century. And the things that we suppress can direct our lives. We need to make the unconscious conscious. We need to bring the things that are suppressed in our bodies up to be witnessed and experienced. And this is what psychedelic therapy is all about. And if we go back to ancient Greece, angst versus melancholia. Like, there was great wisdom thousands of years ago. Angst was part of life. It was part of the human condition. So the Greek philosophers and physicians of the time recognized melancholia as perhaps a disease in our current concept of that word, whereas angst was a reaction to some distress or upset in one's life. And overwhelmingly, most of the patients that we diagnose as major depressive disorder are struggling with angst as opposed to melancholia. And the source of the angst, when we go upstream, I often say, if we're going to be discerning, we need to not be blinded by the smoke, but get through the smoke to the source, to the fire. And at the source of so much smoke, and let's be clear, I'm not talking about the psychotic disorders here, but the psychotic disorders are a very small percentage of the burden of suffering. It's the anxiety, depression, PTSD. And we have all these different labels. You see people with 6 different diagnoses and a different medication for every diagnosis, diagnosis in quotes. When you go upstream, you can see that the unifying mediators are trauma and disconnection. Trauma and disconnection. And Shannon Dames, who works with me in the Roots to Thrive program, talks about psychedelic medicines as medicines of connection, coming back home to connect, not just out there, but in here, connection within and without. And we have become, if no one, this isn't news to anyone, we've become increasingly disconnected within and without. And COVID, of course, has just accelerated that. So if we go upstream and come back to holistic health, body, mind, spirit. And so if we are only doing therapy above the neck, we're not going to get the best outcome. CBT has its place, but unfortunately, we can't, well, it doesn't make sense to push everyone through the same care pathway. The toolbox has to be large, and the toolbox has to be specific to the individual that we're treating, as opposed to saying, well, this is what I specialize in, so that's the treatment they get. And it calls us to be humble and curious and be truly lifelong learners, and recognize that we are not experts. And when we believe we are, then we lack curiosity and continue perhaps with the same failed strategies. And to preserve our myth of expertise, when the patient doesn't recover, we say it's their fault, they're treatment resistant. So this is the holistic health, whether it's psychiatry or integrative medicine, is recognizing that toxicity or deficiency in any of these areas will result in disease. So I often ask, a patient, I'll draw the Venn diagram, I'll say, give yourself a grade on each of these from A to F. And I invite you on the audience to do this yourself periodically. How am I doing? Right now, the spiritual thing can get people go, oh, what's that? Right. So spirit is about connection, meaning, purpose, compassion for yourself. And this is a slide I borrowed from Shannon Dames, just the sort of the pyramid of the hierarchy of our needs. So once our basic physiological needs of shelter and food are provided, then we have the higher order needs of connection, compassion, purpose, feeling a sense of creativity, authenticity, and community, right? And community, to be seen, to see ourselves and to be seen and witnessed by others without having to put on the mask and the cloak. And increasingly, folks in our current culture are having to armor up and mask up to go out in the world. And they become more and more disconnected and split off from their authentic selves. And it would shock you how prevalent toxic narrative, shame, guilt, I am not enough, how pervasive it is, even among those who seem to be functioning at the highest levels. Just like the duck underwater, things are not so good. And healthcare providers are some of the worst with respect to determinants of health. And we're certainly seeing that in the work we're doing, people coming through the ketamine-assisted psychotherapy program, overwhelmingly mental health, health professionals who are really struggling with the status quo. So when we don't have these higher order needs met, sense of connection, purpose, compassion for self, now, this used to be, it's where we came from. This is quite recent. We lived in community, we lived in tribe, where everyone had a place, a purpose, and was celebrated. And we were not evolved to live this way. And this is the resurrection of psychedelic medicine, because psychedelic medicines help us to come back home to experience connection within and without, in community. And without that, this is this chronic stress response that we're subject to. So we are all on the trauma spectrum. Remember, PTSD is not only someone having a life or limb threat. Your neurobiology doesn't know the difference if someone had a gun to your head 2 years ago, or the chronic stress response of going out and armoring up in a world where, in your work, where there's never enough time, never enough resources, and often a lot of moral distress. So we have this chronic autonomic hyperarousal, which is PTSD, just from living in the modern world. So here are some questions I ask to sort of flesh out the spiritual aspect of the person, how they're doing. And I would challenge you or encourage you to ask these questions, not just of your patients, but of yourself. And the results will absolutely surprise you. Right? How do you feel about yourself as a person is a screening question I often use, just broadly. And then I will ask them to respond to the following statements on a continuum from strongly agree to strongly disagree. I am a failure. I am enough. I have a clear sense of meaning and purpose. I feel much shame or guilt. And this just lights up like a Christmas tree. The patterns just never cease to surprise me. It's actually rare when I get positive responses on this set, even among people who seem to be presenting well. So when we are not doing so well with these, there's this spiritual or existential despair. And that's not going to respond to bumping up the Cipralex, right? So again, psychedelic experiences really help us to come back to that sense of witness. The authentic self is the being self, the human being that is witnessing the doing, but I am not that. And it's only when our mind or ego is offline that we have this more expansive, and some would say more authentic level of consciousness. So this level of consciousness is the waking dream. And one of the problems with this level of consciousness is our senses trick us into this illusion of separation. So we see about 4% of the visible universe. So this is a waking dream, and it creates this subject-object split where I am separate and split off from everything. And of course, our culture is reinforcing that in spades, right? The rugged individualist, the Donald Trump. I think Donald Trump as president was a call to action, if ever there was one. What are the values that our culture is espousing? So a couple of quotes I really like from Duncan Grady. He's a Blackfoot elder. Talks about a transformational experience of self, like sitting in front of a mirror where you cannot lie to yourself anymore about who you are. And a reference to the inner healing intelligence, which is such a big part of psychedelic work, going inside, right? The felt sense. Better to go in before you go out, even though the latter is far more seductive. So we have a gut brain, we have a heart brain, but they're silent brains. And we only access that when the mind is offline. And we can do that with deep states of meditation. And of course, all this psychedelic medicines through different mechanisms allow us to access that wisdom in the body and coming back to that experience of authentic self. And in that realm, we have this unity consciousness, a sense that we are not split off from anything. And some great quotes over the millennia. I am that, thou art that, and all of this is that. Aham Brahmasmi, I am the universe, and I am nothing and everything. And the nothing, of course, is at the level of the doing. I am nothing. If I am now, I will be nothing in the future. And when we attach to that for our validity, then of course, as we age and the roles change, we get very distressed indeed, but everything at the level of being. And the knowledge of something is best embedded, or the experience of something is best embedded in the knowledge of it. So it's really important as we all sort of clamor to bring these medicines into the mainstream, that we don't just make it another prescription, another pill, right? Because the patient needs to have the sense and the knowledge of what it is they're about to experience and have the right support. So I'm excited, but at the same time concerned, because I see a great feeding frenzy to get these things going, and not always with the highest intention or awareness. And the relevance of community with these medicines. Kohut talked about the mirroring transference, not just seeing yourself, but being seen by others. And that makes the experience a more embodied experience. And this is a saying from the work we do with ketamine. You come for the ketamine, but you stay for connection with community, a community of practice. And just finally, again, my concern about the medicine is that it be in a container of setting, and integration. But I'm sure you folks have talked about this at length before. This is not unique to, and I believe Pam is talking next month about the importance of appropriate training, because much of what we learn in psychiatry or psychotherapy is not so relevant to the psychedelic context, where there is more of an emphasis on going in and accessing the wisdom that's in the body and holding space for that. So it's really important if we have, I often say, we need to have conscious practitioners working with conscious medicines, because that we need to hold that healing space for our patients. And we can't support them to land there if we are not holding the mirror up for them metaphorically and being there ourselves. So I think I'll stop there. I'm just a little bit past the time. Thank you for your attention, and sorry about the wonkiness getting going at the start.
Wonderful, all good. Thank you so much. Such, yeah, a very interesting presentation, and I'm sure many of the other people here could agree with what you've said, even if some of it is a little bit controversial. It's so important to bring these pieces of information forward and start thinking about it in a different way. So thank you so much. So we'll do breakout rooms. We'll do 7 minutes. So 7 minutes, not quite in heaven, but 7 minutes in a breakout room to just collaborate, chat, network a little bit. You could go over where you're from, what brings you to these series. If you're curious about psychedelics, any questions that you maybe had from the talk or things that really resonated. And then we'll come back together here with Dr. Watler and do a Q&A. So thank you again so much, Dr. Watler, and we'll break out and come back in shortly. And Kirsten, I believe yes, there we are. So just join the room as you're prompted, and then we'll come back here shortly. Thanks again, everyone.
Am I to join a room, Jenna?
That is entirely optional. If you want to relax and have a drink of water before
I
your
probably
Q&A.
will. I just got to call
Yeah.
and check on my old dad. Yeah. All right. I'll just
Absolutely.
Yeah.
We'll see you back in 6 or 7 minutes here.
Hi, Jenna. It's Karen Kowski. Sorry,
Hi.
there was a breakout room on my screen, but
I
it's gone.
know.
That was my
actually happened
fault.
to me.
I closed something by accident. Sorry. That
Oh,
was
okay.
me. Sorry about that. Sorry,
Oh,
Kirsten.
okay.
My fault.
Okay,
We'll
I'll
all go
see
back
if I
in.
can fix that. Are you able to go to the room now, or?
There's nothing here to
Still
click.
not-
No, I think you have to
Yeah.
reset it up. Sorry.
This has been a whole night of Zoom. I
I
was
didn't
actually
realize I
running a
had
group
that
visit
ability
earlier.
to do that.
I couldn't even get connected initially.
That was a really short breakout.
Well, we can just have our breakouts here. Right?
We could, yeah. Why not? Oh,
I
there
think,
we go.
yeah, I think we can
Thank you.
do it now. Good luck, everybody. Sorry about that. All right, I think we're all back. I'm not sure if everybody had that echo issue that we did. That was a little tough. Lots of, good. Lots of Zoom issues today, but I think we're surviving. So we're going to move on to the Q&A. So it's going to run from about 7:45 to 8:25. Please enter your questions in the chat box, and Dr. Watler will get to as many questions as possible in that period of time. I'm going to read them out, and that's just for efficiency. And so I will go to the chat. And I'm not seeing any questions yet. You must have questions from that fantastic talk. So please don't be shy to enter your questions here for Dr. Watler.
Can I jump in and just ask one? I can ask it faster than I can type. Crosbie, can you get
Yes,
a
thank
lot
you.
of us are working with learners and trainees. What's your approach to the young, malleable mind with your approach?
I think it's fostering a culture of lifelong humility and curiosity, and always looking for a better mousetrap, and never being seduced by the myth of expertise. And coming back to the values and just the basic scientific method, which seems to be thrown under the bus so often when in the way we care for patients, right? Not looking at, stepping back and having a witnessing awareness of what's going on. After the third or fourth augmentation or course of ECT and more biological treatments, just saying, maybe we got to come back to the drawing board here. And the imperative to do something should not trump the rationality or lack thereof of what is being done. Because I think there's a lot of therapeutic despair in psychiatry, where when our patients are not getting better, we feel we have to do something, and encouraging learners to have a culture of stepping back, going back to the drawing board, right? Is there something we're missing here? And having a very inclusive discussion about that. And the unfortunate norm, I guess, is each specialist sort of is captain of their own ship, and rarely do we come together as a community and have these kinds of discussions. Yeah, so to really embed themselves in a community where there is that shared humility and curiosity and sharing of ideas and insights.
Great, thank you. I think Johnna had a question. How do you work with patients who are more interested in a pill than a lifestyle change or intervention such as therapy?
This is the bane of my work, because I'm having to undo so much narrative, right? I have eating disorder, I have PTSD, my depression, my ADHD. So there's this identification with the label and the diagnosis. And it's like digging yourself out from under a pile of shite. It really is. So, I mean, so much of my time is retelling the story and being credible about that, right? Because I've had people tell them stuff, and now they're hearing someone say, well, maybe not. So I really have to be careful how I go about it and be going to the data, and just as the data I said earlier, most patients have drunk from the punch bowl and truly believe that depression is not enough serotonin in the brain, and that these antidepressants are definitive treatments, because when they hear antibiotic, antidepressant, right? So yeah, it's first of all, deconstructing for that individual patient their body-mind-spirit interface, and then telling them a story of where they're at this point in time as an adaptation as opposed to a disease. And that when we get upstream, I often use the analogy of baking a cake. When you have a recipe, the outcome's not a surprise. So to engage them in a positive, inspirational way, if you will, that, because very often these folks are very jaded and pessimistic and disappointed and even angry at the chronic disability and the failed promises. So I have all that I'm swimming upstream against. But I find if I tell the story of, I use examples. I say tennis elbow is not a disease, it is an adaptation. And here is how what's going on with you could be an adaptation, and invite them to participate in an experiment. And using, again, the question about learners, we should be using these PHQ-9s and GAD-7s, not to diagnose a disorder, but as a marker for the severity of distress, and doing baseline and checking in with them. I find that very helpful. And especially at Cedars, when I see someone and it's okay, we're not going to change your meds, or we may even get you off your meds, and let's launch another approach and let's track it. Let's see how you're doing. What do you got to lose? And then it's just jaw dropping when you get upstream. You see the PHQ-9s and the GAD-7s plummet, right? And so that's the kind of evidence that I want to, I put forward to them as they're walking out the door. I say, look, here's what happened, right? With less meds or no meds. And so that's, but it's heavy lifting, because there's so much conditioning and belief and attachment sometimes, right? Because sometimes patients, the diagnosis is sort of a get out of jail free card for personal responsibility, right? So sometimes they get a little bit angry because now they got to do some work. I'm not just going to fix them, right? And this is, again, big part of psychedelic medicine. I don't fix you. I bring you to a new awareness, and your life, your choice. What are you going to do with it?
Yeah, thank you. That sounds like an unlearning that starts with us, and we have to transition that to the patient. That's great. This question is from Jan Ray. Do you have favorite priorities for improving microbiome / decreasing inflammation? I have read that soldiers with high CRP levels are more prone to come back from combat with a diagnosis of PTSD.
Absolutely. We know that folks with PTSD have high association with inflammatory markers, and the gut, the biome. I mean, the gut brain. I mean, the gut should be the first brain, but it's also the seat of our immune system, and so absolutely. I mean, you saw the Venn diagram: body, mind, spirit, dysbiosis and inflammation. Nutrient poor foods, all of it, and with depression, very common perpetuating factor for depression is inflammation, right? So this comes back to why it's so important to deconstruct the individual, the patient as an individual, and not some might need more of that functional medicine, metabolic, reversing metabolic syndrome as part of it. And so again, as I said, just looking at that Venn diagram of body, mind, spirit, and someone may have a lot going on at the level of the body and metabolic disease and inflammation. And if I don't have the expertise, I need to have the awareness and connect them with the right support. And that's, I think, where a tribe, a team really comes in. And I think medicine more and more, as opposed to the rugged, independent practice has been the model, is if we can lean on our colleagues and we feel we don't have to do it all and know it all, but we need to have the awareness so we can tap the right resource.
The next question is from Josh. Dr. Watler hinted at the importance of the spirit to the human psyche, but could he be more explicit about the role of spirit, the role spirit plays in depression and anxiety? Could this be what is lacking in the modern DSM-driven approach? Maybe a taboo topic.
Yeah, to be fair to DSM says in the preamble, it is atheoretical with respect to causation. Like DSM does not attempt to define the cause of these conditions, right? But yeah, I mean, spiritual or existential despair, I'm always, and this is, when I engage anyone around spirit, I need to be very cautious because people hear that and they think fundamental religion, right? So when I speak of spirit, I'm talking about a sense of connection, meaning, purpose, self-compassion, self-awareness, an awareness of our elder that works, Elder Geraldine, who works with our Roots to Thrive program, talks about the inner pilot light, that sort of silent witness that is the constant in our lives, right? So I'll often talk about on the day of our birth, we are actually most connected with our authentic selves, the witness with no narrative, and having that sort of construct as the spiritual self, that the self who is aware without judgment, attachment, narrative, and having a sense of self-awareness and then meaningful connection and purpose and community. And when those determinants of thriving are not there, then there is often, not as a disorder, but as a natural and logical consequence, that there is existential despair. What is the meaning of all of this? Who am I? What is my purpose? And it can, many flavors, depression, anxiety, usually a interface of the two.
Thank you. This is a great question from Johnna, one that, makes me think. Psychiatrists, we have a fair bit of time. We also get paid for our time. But one challenge in the healthcare system seems to be the lack of time, short visits, overbooked clinics, etc. Any advice to work with these situations, yet still provide quality, holistic, upstream care to patients? And I think of family physicians who might have 15 minutes to see a patient.
Yeah, I think one of the things that sort of led me out the door with Island Health was everyone's a psych patient. We'll never have enough time if we medicalize the human condition. So that's the reason we don't have enough time, is because I don't know about your training, but in my training, I had no training to deal with the vast majority of what I'm seeing. Our training really was about diagnosis and prescribing, and with a little throw a bone to a little bit of CBT. And sure, you could do electives and seek other things out, but at least in my day, one could get through a psychiatry residency and do very well, but have no capacity to deal with the distress and the angst that is not medical. So I think that's part of the problem, is why is this at psychiatry's, why is it on psychiatry's doorstep? You know, when I was on call for many years, everyone coming in that was distressed was a psych patient. And I was busy and never had enough time. And it's not just having the time, not having the tools to, you know, to do the work. So I think we got to step back and say, do we need more and more docs doing more and more the same thing? In a production system, I think it's important to step back as we hurry to catch up with the widgets coming on the assembly line, say, why are there so many widgets on the assembly line in the first place, right? I think a lot of those widgets could come off the assembly line if we had town halls where, you know, in community where people could, in a multidisciplinary way, do some community development, education, right? It's not more and more individual docs seeing people without the tools to get to the upstream. And I think it's a real important part of medical training, but what makes this medical, right? That's the, how did this end up, how did so much of this end up on our doorstep? And this is, you know, a perspective that's put out. Maybe psychiatry should have restricted its domain to things that are qualitatively different than normalcy, bipolar 1, schizophrenia, obsessive compulsive disorder. But all the worried well have come into our silo. So no wonder we're overworked, because that's a large cohort. And psychiatrists per se have no expertise specifically. In fact, much of our learning has to be unlearned to work with these groups.
Yeah, excellent points. Thank you. The next question is from Dale. Many of your statements sound like the response-based ideas developed by Alan Wade and colleagues. Have those ideas been part of what has inspired you?
I don't know the name Alan Wade. Sounds vaguely familiar, but I don't know. I think the thing that inspired me, frankly, and I can send it to you, Johnna, to send out. Anyone who's not read Joel Paris's little books really were a wake-up call to me. And this, it's all evidence-based. I mean, this is not just my view. Actually, in the Canadian Journal of Psychiatry, I think it was 2012, they talked about the overdiagnosis of bipolar disorder, right? So this is, we know that psychiatrists are biased towards diagnosing conditions that they're comfortable treating. So we have, without a doubt, and it's in the literature, an overdiagnosis of bipolar type 2 versus borderline personality disorder, right? Because psychiatrists are very uncomfortable with borderline personality disorder. So it's not my view. I go to just the evidence of what's going on. And the evidence, as I said, is very clear that the conventional approach is not working. And to be fair to psychiatry, I think there's some shift, and we see maybe some you know, courses at the CPA and so forth looking at this. But you know, I think there's a phrase in holistic medicine that radical change requires a radical intervention. We can't afford a slow shift. This needs to be a quantum leap, because people are really, the burden of suffering is just exponentially higher. I don't know if that answers the question, if maybe a bit more specific about Alan Wade, but.
Yeah, does anyone want to chime in about Alan Wade? I'm not sure about that myself. Or we'll just go on to the next question. And if someone has a comment, that'd be great. You can just jump in. Next question is from Johnna. I found the part about us only seeing about 4% of the visible world quite interesting. Could you comment more on this and why this is so? I wonder, could we use this piece of information with patients to help shift their perspectives?
Absolutely. Yeah, this was a real, I did some studies on meditation and the old teachings around levels of consciousness, and came across this term in ancient India, Maya, the illusion of the senses. So we see it, and you can Google it. I can't recall if it's exactly 4%, but it's single digit. We see single digit percent of the visible universe. And every species constructs a different reality, right? Based on their sensory apparatus and the bandwidth of their sensory apparatus. So you will see described many different levels of consciousness. The dreaming consciousness, we believe our dreams are real. And then we wake up, we say, oh, that was a dream, this is reality. And this is actually the waking dream, because we construct this reality, again, based on this Maya, the illusion of the senses. So our senses fool us into this disconnection between ourselves and everyone around us, when in fact, and this is a big area of work, is energy medicine, the field, right? So in fact, the human heart has an EMF field that can be projected 20 odd feet away, right? But we don't see that. And there is so much else we don't see, matter, energy, but there is, and it can sound a little wonky until you start to play with it and experience it, the felt sense. The felt sense, I think 500 million neurons in the gut, 500,000 neurons in the heart, all of which have their own intelligence, but silent intelligence, and a different reality than the eyes. So yeah, it's just taking our senses less seriously, right? Is we see such a small part of it. And that limits what we're able to study, right? We say science. Well, the scientists can only see just a tiny portion of what actually exists. So if it's starting to perhaps be a little more open and curious to taking ourselves and our senses so seriously. And again, the postulation is that the really high, the God consciousness, the really high levels of I am this, I am everything and you are too, and I'm God, you're God. Some would say that is the highest level of consciousness and perhaps a more authentic level of consciousness, but we are blind to that because our senses trap us in this very, very flawed, limited view of things.
A question I quite like from Josh here, a question that I have too. Have you seen psychedelic medicines make a positive impact on these body-mind syndromes like chronic fatigue, chronic pain, fibromyalgia, irritable bowel, etc.?
Absolutely, absolutely. And more we are aware that this is not new, that the somatization disorder, right, in psychiatry, that all these hysterical things described over the years. So much of our day-to-day experience, our challenging memories and emotions are literally suppressed in the body. And we have these complexes of stuck, repressed emotions and memories. And the older we get, the more it piles up. And not surprisingly, as the boomer cohort is getting long in the tooth, we see it getting to a tipping point, right? Where the container just can't keep it all anymore. And then we have you know, disability, a significant depression, anxiety, medical symptoms that defy diagnosis, chronic fatigue syndrome, all of this. And with psychedelics, when the person, there's this really good concept, you may have heard it, but not a concept, it's a fact about the window of tolerance, the window of tolerance. So if we are above the window of tolerance with an experience, then we need to suppress it somehow, right? And psychedelics help broaden that window of tolerance so we can re-experience these suppressed memories and emotions from a grounded place. And that's where the whole thing collapses. It's basic behavioral science, exposure and desensitization, right? So if we're able to revisit all these suppressed memories and emotions, but from a place of calm grounding, then we don't have the body-mind cascade of reactivity reinforcing the body-mind complex, and it just collapses. It's just exposure and desensitization. It's a behavioral law, if ever there was one. So that's a kind of way I like to conceive of how things get stuffed in the body, but how they can come up to be witnessed and re-experienced and develop a different relationship with them. The memories don't go away. This is a very big thing in trauma. They wish they could get rid of the memories. But what if we can create a different relationship with them? So the weather is a good analogy I use in my work. I say, you're not denying that there's a storm going on, but it's very different if you're out in the storm versus witnessing the storm from the space of a secure building, right? And it's all about creating that space where you don't have to deny what's going on, but it's no longer smothering or overwhelming you.
Great analogies, thank you. Dale shared the link for anybody who's interested in the response-based work. So thanks so much, Dale. And Jenna has a question. Any thoughts, input on how we can help ensure psychedelic therapy moves forward in a good way and doesn't just become another pill, for example?
Well, I think that's the challenge right now, because there's no, and this audience would be very aware, the potential benefit from these medicines are not under discussion. It's been well demonstrated. What I believe is holding things up is how do the various governing bodies and government, how do they have quality assurance and safety? And I think that's where, you know, we need to really get to the front of the queue, demonstrating the benefit from programs that are doing things in a proper way with the respect of setting integration. And I think the more data we can get showing that this approach is effective, and perhaps trying to influence or even set up training programs that are aligned with the highest use and the best container for this work. So I think there is an urgency, because we know and we hear, just like puppy mills, we're going to have ketamine mills on every corner, right? And so, yeah, I think this is a real, that's one of the reasons I'm still in the game, is feeling that there is a responsibility to have a strong influence when it comes to training and accreditation for protocols. And I think,
and do you think there's,
go ahead.
No,
you go ahead, Rob.
Do you think there's an appetite in the Department of Psychiatry to have residents, psychiatry residents, I guess in Department of Family Medicine as well, taught specifically about psychedelics? Like, I work with residents all the time, And we touch on this occasionally, and they have had nothing so far. And I'm shocked with the trials that have come out on psilocybin and MDMA and ketamine, nothing. And do you know what's happening there? I'm just curious.
No, I don't. I do know, and Pam will know this too. I mean, she's on the emails with me. I think we have about 3 senior residents in psychiatry that are banging on the door. And my concern is if psychiatry doesn't get on the bus real quick with their training programs and so forth, that this is the information age, and the bus is just going to go right around the whole thing, right? This is a real critical time. But I think the challenge is, I mean, most of the people who are at the top of academia right now probably had very conventional training. And perhaps this belief that, you know, drugs are drugs, I mean, street drugs. And there's still a lot of prejudice, I think, out there. And I love analogies and metaphors. So, MDMA, ketamine, psilocybin, people say, or LSD, well, those are drugs. Well, fire is potential, right? Fire burning down your house is a catastrophe. Fire in your fireplace is a good thing. So it really depends on the context in which they're used. But there is still that. I think there's less of that, frankly. Sometimes I mentioned to a colleague a couple of years ago, I think I said, this person really, benefit, I think, from a psychedelic therapy approach. I don't think you get that anymore. I think there's just enough. It's starting to have a little cachet. But I'll be frank, I think it's really humbling to have spent so many years becoming an expert and then truly acknowledging, oh my God, I got to learn all this, I got to start all over. I got to learn a whole new thing, so I think we got to incentivize that somehow, right? How do we incentivize that and inspire people? Because everyone got into medicine or the helping professions to fix people, right? And I think it's if psychiatrists could have more experience of seeing people actually transform and heal, so I think it's just curious and just engaging. But yeah, I think too, just being the change, just being an example and showing up, so people are curious to show up in a way that may surprise people, and then they're more interested.
Yeah, I don't think it will take a lot. I think once people have a sense of what can happen, their mind shifts very, very quickly. So I think we're getting there. It's like an infection.
I think talk about a pandemic. It's so much word of mouth, and it's quite exciting. And I feel that this is. I think COVID and Donald Trump have actually accelerated. If we can look at, is there any good that can come from this? And it really has squeezed the fruit to a point where I say, Jesus, we gotta do things differently. We gotta find a better mousetrap here. Yeah.
I'm gonna ask this last question as quickly as I can. It's a long one from Teresa. I feel that I've always been very cautious to treat depression with pills only and use them quite rarely. I do see and believe that there is a physiologic depressed ability of the central nervous system to communicate with itself, aka depression. And when I find a general flattening of all the normal functions of the brain, I often find these patients respond well to reuptake inhibitors. This is in strong contrast to the reactive depressions, as you mentioned.
Yeah.
Do you feel that there is equal or also benefit for those with non-reactive depression, aka those who tend to do well consistently with a bit of N or S reuptake inhibition, despite some of their side effects? And would these patients benefit as well from microdosing of psychedelics?
I think I got lost partway through there. I was doing pretty well for a while. So the initial part was around, I'll just go with the first part, and just what I'm understanding from the first part is folks that are generally consistently flat, anergic perhaps, tend to do well with medication. Yeah, so there's a term I find helpful, a distinct and enduring quality of depressed mood. That's often a marker for melancholia. A depressed mood that is independent of context, has a life of its own. And often, as was said, there's a lot of psychomotor slowing and the classic neurovegetative features of depression. And yeah, those are a different beastie entirely from the angst folks. And yeah, they do well with meds. The second part I got a bit lost on, Rob.
Yeah,
The second part is just, do those type patients, the melancholic ones you're discussing, do they also benefit from the microdosing of psychedelics, or is it a different bird altogether?
Well, I think I am not an expert on microdosing psychedelics, but I think if someone were a melancholic, it would just be a tiered, again, the scientific method, change one variable at a time and not try to bring in too many things at once. So, if someone had a melancholic type depression with that consistent, enduring quality of depressed mood, right? One of the features of a non-melancholic depression is reactivity of mood that is reactive to the context, often the interpersonal context. And that actually is one of the ways we distinguish borderline personality disorder from classic depression. Is the person with borderline personality disorder, they have interpersonally bound affective instability, right? Where they're depressed in this instant because their boyfriend left them, but then, tomorrow they are totally different. So yeah, for the melancholic subtype, my usual approach is an antidepressant, but also looking at the spin-off, because you may have a melancholic depression, but you also have a lot of negative spin-off and narrative from there, a lot of shame, a lot of guilt, a lot of blame, right? So a lot of supportive psychotherapy, confronting guilt, instilling hope, and very important because people don't kill themselves very often, usually for what's happening today. Is projecting that it'll never change. So I think that's a big initial step in our intervention is being a cheerleader and instilling hope that, yeah, it's happening now, but it can shift, and here's a path out of it. Beyond that, I would just see how they do and look at all the tools on a very individual level, and microdosing could be part of it. I would be consulting with someone I know about that, because I don't prescribe microdosing myself, but I would be aware of what psychedelic medicines at a macrodose might be helpful based on what's going on. Yeah, of course, if it's PTSD versus something else. Because the thing about depression too, it's often comorbid with so many other conditions, right? So often trauma. Yeah.
All right, we're over time. That was a fantastic discussion. Thank you so much for sharing your knowledge today, Crosbie. You've brought us back below the neck, as you say, where the healing happens. You've also given voice to what we, I think, implicitly understand about the value of connection. So again, we really, really appreciate it. Thank you. Any last thoughts? Any last thoughts, Crosbie, from you?
No, just a privilege to share space with people who are curious and looking to make a difference. Yeah, it's always good to show up for this kind of work and this kind of community.
Great.
Yeah.
And as far as the participants, please complete the evaluations for this session. The link is in the chat box and in the meeting invite that you were provided. The next session is December 8th, 2021. I can see Dr. Pam Crisco in the audience, and she'll be giving us a talk on how to get more psychedelic experience and training. So I think there's lots of people quite interested in this. That should be exciting. And you'll get a registration link as before. And thanks so much, everyone. It's been a pleasure.
Thank
Good
you.
night.
Thank you. Take good care. Good night.
Thanks, everyone.
Thanks, Crosby.